Functional bowel disorders. There are a range of functional bowel disorders, Table 38. The rest of this section concentrates on the commonest of these, irritable bowel syndrome. Etiology, pathophysiology, and pathology. The hallmark of the functional gastrointestinal disorders is altered, usually increased, visceral pain sensitivity. This may be associated with increased release of 5-hydroxytryptamine, 5-HT, serotonin, from enterochromaffin cells in the gut, but central, psychosocial, neurohumoral factors may be important, and it has also been suggested that alterations in the intestinal bacterial flora may be involved. This is supported by the high incidence of patients presenting with irritable bowel syndrome following culture-positive gastroenteritis, use of broad-spectrum antibiotics or pelvic surgery. The role of stress is uncertain, but there is a higher incidence of psychological disorders in those who seek medical advice. Epidemiology. The prevalence of the functional bowel disorders depends entirely on definition. It is estimated that only 10 to 50% of patients with functional gut symptoms consult medical practitioners, yet this represents as much as 5% of all general practice consultations in the UK and up to 40% of gastroenterology referrals. There is a female-to-male predominance of 2 or 3:1. About 75% of patients diagnosed with irritable bowel syndrome will continue to have chronic disease. Clinical presentation. Common. The agreed definition of irritable bowel syndrome is as follows: at least 12 weeks, which need not be consecutive, in the preceding 12 months of abdominal discomfort or pain that has two of the following three features: relieved with defecation, and/or onset associated with a change in frequency of stool, and/or onset associated with a change in form, appearance, of stool. Symptoms that cumulatively support the diagnosis of irritable bowel syndrome include abnormal stool frequency, more than 3 motions per day or less than 3 motions per week, abnormal stool form, abnormal stool passage, urgency, straining or incomplete evacuation, passage of mucus, bloating or a feeling of abdominal distension. NB. There are some clinical features that should not be attributed to a functional cause without careful further investigation, including dysphagia, anorexia and/or weight loss, mouth ulcers, nocturnal diarrhea, rectal bleeding. Physical signs. There are no characteristic physical signs. Investigation. The extent of clinical investigation must be tailored to the individual patient. A detailed history, including a good dietary history, is central to both the correct clinical diagnosis and subsequent management. Investigations depend largely on the patient's particular symptom complex. A recommended screening panel would include FBC, erythrocyte sedimentation rate, thyroid function tests and celiac antibodies. Where appropriate, consider stool cultures. Patients aged over 50 years presenting with altered bowel habits should have a colonoscopy. Differential diagnosis. The following should always be considered: celiac disease, hypolactasia, inflammatory bowel disease, giardiasis, depressive illness, gastrointestinal malignancy, and thyroid disease, hyperthyroidism and hypothyroidism. Treatment. NB. The most important part of the management is to listen to the patient. After a thorough history and physical examination, the qualified reassurance of being told that there is no objective evidence of physical disease may be sufficient to lead to an improvement in symptoms, or at least the resulting concern. The treatment of irritable bowel syndrome sufferers is often disappointing but should be tailored to the predominant symptoms of the patient. Diarrhea. Dietary exclusion. Common problem foods include wheat, dairy, and eggs, Many patients benefit from a low-fiber diet and find their symptoms worsen with increase in dietary fiber. Antidiarrheals, loperamide, diphenoxylate, 5-HT3 antagonists, e.g. allosterin, but concern remains over the association with ischemic colitis. Amitriptyline. Constipation. Fiber supplementation. This may be achieved by dietary means, but may result in increased pain or bloating. Non-fermentable bulking agents, e.g. Normacol, may be more efficacious. Laxatives, stimulant laxatives, e.g. Senacot, are not recommended for long-term use. Osmotic laxatives, e.g. Movicol, Macrogols, or other polyethylene glycol-based preparations, are most effective. Biofeedback, particularly if straining is a predominant symptom, retrains individuals to defecate normally. Pain and bloating. Anticholinergics, e.g. mebeverine, Alvarine reduce bowel spasm. Amitriptyline has anticholinergic effects and works on serotonin pathway, effective at small, 10-25 mg, doses independently from presence of depressive symptoms, but side effect profile may limit use. SSRIs act on serotonin pathway, fewer side effects than amitriptyline but data less convincing. Hypnotherapy. Prognosis. Most patients will continue to have intermittent gastrointestinal symptoms and some may develop more overt psychiatric problems. Mortality is not increased.